Good morning, everybody, or good afternoon in the East. Welcome to Concurrent number 9, Virtual Community Care. My name is Naima Salemohamed. I'm currently with Accenture and an eHealth 2022 ambassador. This session will be comprised of 4 rapid style presentations. And if we have time for questions, we will address those at the end of all the presentations. You can also use the chat if you want to chat with any of the speakers. You are also encouraged to connect with any of the speakers after the session via the virtual event platform. First up, we have Paige Campbell, Research Assistant at the Cumming School of Medicine from the University of Calgary. Welcome, Paige.
Hello, thank you very much for listening to my presentation today. As already said, my name is Paige Campbell, and I'm here to discuss virtual primary healthcare for Indigenous patients in Alberta, Canada. First, I'd like to quickly take a minute to acknowledge the land that we live, work, and play on. So this would include Treaties 6, 7, 8, which also includes the Blackfoot Confederacy comprising of the Siksika, Piikani, Kainai First Nations, the Cree, Dene, Saulteaux, Nakota, Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations, and the Tsuut'ina First Nation. We acknowledge the 6 regions of the Métis Nation of Alberta. So the healthcare challenge I'm going to talk to you today is about the health disparities that underserved populations are currently facing in Alberta. Indigenous people residing in Canada experience disproportionate health disparities that non-Indigenous peoples aren't currently facing. There are a couple of examples there on the chart on the right-hand side. As First Nations on reserve are currently experiencing chronic diseases at a higher rate than the general population. For diabetes in particular, First Nations people are actually experiencing diabetes 4 times higher than the general Canadian population. Even though there are these health disparities that First Nations peoples are experiencing, there's actually great resilience within the province in that First Nations and non-First Nations people with high school and post-secondary education actually have the same amount of education at the end of the day. So it's great to see that there's education as a great equalizer for some disparities, and the Indigenous people in Alberta are definitely taking advantage of all the opportunities out there to kind of mitigate those inequities. And lastly, lack of culturally safe, accessible healthcare for marginalized populations, such as Indigenous Canadians, are definitely a challenge that's out there today, and it's exacerbated by COVID-19 specifically right now. And this is just a general list of all the barriers that Indigenous peoples in Alberta are facing when they're looking at either seeking out healthcare or maintaining good health. So this is a general list. Again, there's so many barriers. We could talk about this all day. There's a lot to discuss and break down. But on the left here, you can see a visualization of the geographic area that one virtual care clinic, I should say, in Alberta. This is the population they serve. So all these little blue marks are where the patients are coming from, and they're all seeking care at one virtual care clinic. So you can imagine with this wide geographic area that there can be definitely challenges of time, transportation, limited access to local physicians and services, distance, and connectivity for rural and remote areas. So definitely the biggest barrier that we're going to talk about kind of right now is the lack of culturally safe and accessible care. Equitable access to primary healthcare services is essential for reducing those health disparities that we kind of just mentioned between Indigenous and non-Indigenous populations. And understanding all these factors and barriers that are underlying limiting access to primary healthcare is the first step to really making equitable healthcare accessible for all Canadians as well as Indigenous Canadians. So some examples here when we're talking about rural and remote and northern communities facing barriers, that a lot of these areas rely on fly-in physicians, which is definitely something that takes away from the continuity of care. And then also, if you're on reserve or First Nations people living on reservations, there are long lines and wait lists for seeking out care. Again, some doctors may fly in only for one day a month or a couple days a month. And then there are those long wait lists that definitely inhibit the amount of time Indigenous people are spent seeking out care or even waiting for care that may also contribute to their deteriorating health conditions when you're accessing care and waiting those long lines. So some of the solutions that we have for these long lines of barriers that we have there is that there's one clinic in particular. It's the Alberta Indigenous Virtual Care Clinic. We call it AVIC. So it is currently a clinic where Indigenous people can access family medicine physicians by consultation over the phone or video. So this is definitely impactful. By increasing access, AVIC has seen over 1,900 patients with almost 6,000 appointments since opening in October 2020 to March 2022. And at the bottom chart there, you can see a steady increase in the number of appointments in the graph. And this is definitely an important statistic, is that 92% of patients are actually attending their appointments that they're booking, which is good to include because a lot of times appointments are booked but not actually attended due to all these barriers that we saw in the last slide. Depending on maybe the location or the amount of time it takes a patient to travel into the clinic, or maybe having access to reliable babysitters for dependents, are all things that could definitely impact their ability to attend appointments. So 92% of patients attending these virtual care clinic appointments is a big impact on how many patients are seeking out care and actually gaining access to family medicine physicians. And again, we've actually asked patients about their experiences, and we've asked them how they feel about virtual care. And actually 80% of them believed that they did not experience judgment or racism as they did in in-person care, which is great to see, as the AVIC physicians are actually culturally trained and trauma informed. So they're definitely in safe hands with these patients that are building trusting relationships and definitely mitigating some of those barriers of having mistrust with the medical system. So these AVIC physicians are able to really build these good relationships with these patients to have good outcomes for their health. So these are the references here that were included in the presentation. And if you have any further inquiries or want to discuss anything Indigenous health related with AVIC, there's actually a contact at the bottom of the slide. Thank you so much.
Great. Thank you so much, Paige. That was a great presentation. I would now like to welcome Dr. Brett Belchetz, the co-founder and CEO of Maple, to present next.
Good morning, and thank you so much for having me. It's a real pleasure to be here. I want to talk to you today about building sustainable community health model using virtual care. So just jumping into the problem that we're trying to solve. As we all know, one of the greatest challenges to healthcare in Canada is the enormous number of patients that we know that do not have a primary care provider or a family doctor. So across the country in 2019, we know that 4.6 million Canadians did not have a family doctor. Despite decades of recruitment efforts, in particular, the community I want to speak about is Nova Scotia. Despite decades of recruitment efforts and an enormous amount of resources used, the number of patients without a family doctor continues to grow. So this slide, actually, what's interesting, is already out of date. So this slide says 88,000 patients in Nova Scotia don't have a primary care provider. And actually, since we made this slide, which was not that long ago, the number has already jumped to almost 92,000. And this number, 92,000, is 30% greater than this number was a year ago. So all of the efforts that are being made are actually not paying off to help this problem. Now, we all know this is a critical issue. It results in poor patient outcomes. So people who do not have family doctors, they have an enormous burden of care related to the fact that often they are not seeing doctors at all for many of their ongoing health issues. When they are seeking care, there's no continuity of care. They have to manage their care in places like walk-in clinics, places like the emergency room, where each time they see a new provider who has no access to the cumulative care record that those patients have accumulated in previous visits. And we know that this ends up in potentially the wrong diagnosis, duplicative care, wasteful care, and eventually bad outcomes for these patients. This certainly creates system strain, very expensive to provide primary care in the emergency room. Some estimates say it's 10 times as expensive to provide primary care in the emergency room versus in a family practice. And we know that this is creating huge health disparities across socioeconomic groups across the province and across the country. The other thing that's important to point out is the vast majority, 65% of these people who do not have family doctor reside in rural areas. So this is a hugely rural problem, and certainly a problem that is not easily solved given the disparity of how many more physicians we have in urban areas versus rural areas across Canada. So just wanted to point out an illustrative case of, whoops, I just went too many slides forward and I've lost my slide here. Hang on 1 second. I am going into wrong presentation. Excuse me 1 second. So this is the slide I meant to put up, but just wanted to put up an illustrative case. This is based on an actual patient who attended our program. So Tina, who is not the patient's real name, is a 67-year-old woman who is often taking time off work to wait hours in the emergency department in Nova Scotia for refills of a cardiovascular medication that she requires every 3 months. There is so much related to this condition that is not being cared for, or that requires being cared for on an ongoing basis. So routine preventive care is not being given in the emergency room. She needs advice on her lifestyle and diet. This is given sporadically in the emergency room, but not as comprehensively as she requires. Her prescription refills are being given. Many of her ongoing screening tests that she requires, she struggles to receive. System navigation is very much absent. She's going into the emergency room for many of her acute conditions, but again, without that continuity of care. So all of those things that you see listed there. In the area of chronic disease, we know that chronic disease management, which typically requires ongoing screening care, ongoing tracking of results, ongoing behavior modification. This is something that she's going to the emergency room and walk-in clinics for, and we know that these are not good places for these kinds of care to be delivered. So all of these things that are critical for somebody like this with a complex medical condition, all of these things are not being effectively delivered in the way that this particular patient has been accessing the system. So I want to talk quickly about the solution that we implemented. So we actually designed and deployed a multimodal, sustainable community primary care program that includes both virtual and physical care. So this is what's really unique about this program. So we invited, at the time the program began, we invited 70,000 patients in Nova Scotia without a family doctor to sign up. Of those 70,000 patients, we had a very good sign-up result. Keeping in mind, it's very hard to reach some of these patients. We had 22,000 of those patients registered for the program at the onset of the program. And since then, we've had 15,000 virtual care visits from those 22,000 patients. So a huge rate of participation from the patients that we were able to reach and who created an account. So this program is staffed by family doctors from across Nova Scotia, and they're actually creating additional capacity. So they're not doing this instead of seeing their family practices. These are doctors who volunteered knowing they had extra time in their schedules and volunteered for this program to help unattached patients using a virtual care platform. The program is staffed by Nova Scotia Health. The platform is provided by Maple. So Maple, our company, is just the technology provider. To be clear, we provided the know-how and the consulting for how to set up this program. Now, what's been really cool is that part of this program is built-in referrals to in-person care, where the virtual care physician who is seeing these patients for visits realizes that in-person care is required. And what we're seeing is that the vast majority, about 80% of these visits, were able to fully resolve those patients' care in the virtual world, but 3,000 of those cases across the 15,000 resulted in a referral to in-person. Now, part of this program that we're really proud of is the records follow the patient from virtual to in-person, so that we have full continuity of care both within the virtual platform and across into the physical platform. So been extraordinarily effective. I think it's one of a kind, this marriage of virtual and physical care. A couple of other things, we prevented 5,000 trips to the emergency department for primary care and other issues, huge savings to the system. The patients are extraordinarily happy, rating this on average 4.7 out of 5. The providers are enormously satisfied to be able to use their time effectively to take care of other patients that are outside of their practice that they might not have been able to have help prior to this program existing. Overall, a huge success and a massive model that we think can be employed across the country and by other provinces to solve this crisis of patients without family doctors that we see in Canada. So thank you so much for your time. It's been a pleasure talking to you about this. Anybody who's interested, feel free to reach out to us at getmaple.ca. We have a team that implements programs like this. We'd love to provide more of our know-how to anyone who's interested. Have a wonderful day and take care, everybody.
Perfect. Thank you, Brett. Next to the virtual stage, we are going to welcome Dr. Daniel Rosenfield from the Hospital for Sick Children.
Great. Thank you so much for having me. So as you mentioned, my name's Dan. I'm an emergency physician at Sick Kids Hospital in Toronto, and I'm particularly fond of this 7-minute quick hits. And being an emerg doc, everything's pretty quick. So I'm here today to talk to you about some challenges we've had, and emergency departments and sick kids in particular have been in the news of late, just for our kind of ED, our high volumes and kind of crowding. So I wanted to talk a little bit about something we've implemented a little bit before that to help address some of these issues. But happy to chat more about that at another point as well. So our initial challenge that we're talking about today was that we had a group of subset of families that when we send them home from the emergency department, they need to be followed up within 24 to 72 hours. And if that's for follow-up to see if a fever resolved or if a bruise is feeling better, whatever it is, typically we send these families to see their primary care provider. But as you know, during the pandemic, assuring good follow-up actually became very, very hard. In early phases, of course, many offices were closed or converted strictly to virtual, or weren't available at all, or it was off hours, such as a weekend or a holiday. And before this, we would sometimes bring kids back to the emergency department to be reassessed, which, of course, during a pandemic is not the best idea. You don't want to bring them back into now it's exceedingly long wait times, or before that, and prone to infections and things like that. So we had the idea of how can we follow up some of these kids virtually, and if so, how would that work? Will families will that be acceptable to them? Will their providers? So who's going to do it, etc. So that was kind of the initial thought and challenge. And so, as you can imagine, there are significant barriers that presented to this, even from the idea phase. So the first one was the obvious technical stuff, which many people here would have easy solutions to, but certainly when we were embarking on the journey, it wasn't so obvious. What platform do we use? How are we notifying parents? Who's booking them in? Do we have the human resources to make these changes happen, etc.? There were certainly many clinical barriers. So at the beginning, it was just the acceptability of virtual care. So would a family be okay being followed up virtually a few days later? Would the providers be okay with it? What's going to be the standard of care for pediatrics in particular? So it'd be, the kids can't tell us how they're feeling. How are we going to navigate that? Will our providers buy into it? And of course, workflows are always a big challenge when you're implementing new types of processes. So it was the beginning and middle of the pandemic. There was lots of new workflows in the department. We were putting on personal protective equipment for every patient, and so adding another workflow where we have to figure out how we're booking these patients in, et cetera, was another barrier as well. And then last but not least, we were thinking there's the technical barriers for families. Are they going to be able to use technology that we implement? We don't want to arrange a follow-up and then it can't happen, and then we have more stress on the system and families won't know where to go. So there were lots of barriers kind of thinking about this process when we kind of got started. But what did we actually end up doing? So we'll talk a little bit about the solution and some of the results that came from it. So we did implement a virtual follow-up program. For those of you who know, Sick Kids went live with Epic in 2018. We were kind of one of the early adopters in the Ontario atmosphere. Good luck to everyone who works at UHN in the next couple of days. They're going live on June 4th. So what was helpful about that was that Epic had already implemented a Zoom integrated platform for their ambulatory visits, so general clinics, and we were able to kind of piggyback on top of that. So the workflow essentially was that we would book an appointment in Epic, and the provider would do that. So me as the emergency doctor or the physician assistant would look at a bunch of appointments, book them in, and it would print off on their after visit summary or their discharge summary. So they'd see that they have an appointment in a couple days. We'd have their email addresses. They'd be emailed the Zoom link and the appointment, and they'd be seen by the virtual physician. For those of you who attended the eHealth last year, I actually presented on our virtual physician model. And this is actually pivotal to understanding how this works. We essentially developed a virtual physician early in the pandemic for people who couldn't see patients in person due to personal risk of COVID, et cetera, but still needed to contribute to the department. And they would do things like take outside calls, follow up on late arriving labs, follow up on x-ray discrepancies. And then later we developed clinical tools for them. So we have a virtual urgent care platform that they now staff, and they'd staff the virtual follow-ups. So it was really important that we had this virtual role established in order to have a provider who would see these families in virtual follow-up. So what did we actually do? So to this point, we've actually seen over 700 families in follow-up, and the families like love the system. The feedback we've gotten from formal and informal evaluations has been phenomenal. Some brief quotes I put on here were, it's incredibly helpful. It's a great service. It prevented us a trip to the ED, and I hope that it continues post-pandemic. When post-pandemic is, I guess, is a question we're all asking ourselves, but I think we definitely see a role for it as in the future. Interestingly, from a safety perspective, there were 8 kids who came back to the emergency department of those 700, and all of them were admitted to hospital, and all of them were actually instructed to come back to hospital from the virtual follow-up. So it kind of worked as it was supposed to. It identified some kids who might not have come back, but for that follow-up, and all of them were sick enough to need to stay in hospital. So we're not worried that we're missing any sick kids with this follow-up program, and so that's great. I think the last thing I'll leave everyone on is from the provider angle. I think some of our providers it's a little bit hit and miss. I think some of the time, most of us feel that this is not necessarily the best use of emergency department resources. Most of this follow-up could happen in primary care. As actually Brett mentioned in the last presentation, though, this is a huge issue with families being able to access primary care in the first place. So I do see a role for this in the future, and I think our providers understand that this is a service that's very valued by family members when it is required. So without anything else, I thank everyone for their time. If you need to reach out to me, if you can follow me on Twitter or email me, and I'm happy to field any questions in the chat for the next little while. Thanks so much.
Perfect. Thank you so much, Daniel. Our final presentation of this session is going to be brought to us by Brianne Borden, a portfolio manager at Fraser Health.
Hi, and welcome, everyone. There we go. So I will be discussing with you how we implemented an integrated virtual visit solution in Fraser Health. This was done to streamline workflow and support patient care. I'm coming to you from Fraser Health, a health authority in British Columbia, Canada, that provides services on the unceded and ancestral territories of the Inklepumic and Coast Salish nations. So at the onset of the pandemic, we encountered a healthcare challenge with the introduction of virtual visits into Fraser Health. So as we were moving towards that pandemic mode, and we had to convert a lot of our ambulatory care services in Fraser Health to virtual care, we kind of plunked in a virtual solution, which was Zoom at the time, into our in-person workflow. And here you can see a very basic workflow that was that virtual visit workflow that we were encountering in Fraser Health. So they would review the referral, schedule visits, register patients, request and receive patient information, send reminders, and conduct a visit. So in this workflow, you can see it's very basic. It's a lot more convoluted than this, but we encountered many challenges. And where we encountered these challenges was in these highlighted purple areas. So with the scheduling visits, requesting and receiving patient information, sending visit reminders, and conducting visits. So what we encountered for our business problem is that the clerks especially sometimes tripled and quadrupled their workload. So they were having to book appointments in Meditech, which is our electronic medical record in Fraser Health. And they also had to book in video visit applications, so Zoom in this case. They were having to manually send appointment invites and reminders, and they were having to keep track of all that information, often on an Excel spreadsheet or something for the patient. And then they also had to track that patient's journey through education sessions. For providers, they were having to manage multiple calendars. So they had to manage their Meditech calendar, their Outlook calendar, as well as what was taking place in Zoom. They also had to spend some of their valuable appointment time manually requesting and receiving patient information. So instead of when you're in that patient waiting room and you would be filling in a form and then handing that over to the healthcare provider, instead of being able to do that, you weren't able to, we didn't have an electronic means to do that. So they were having to spend that appointment time doing this. For patients, however, what we realized is they actually really loved virtual, which wasn't that surprising. They didn't have to pay for parking. They didn't have to take time, more time out of their day to have that visit with the healthcare provider at a hospital site often. But they were having some inconveniences around inconsistent notifications and having to manually give information back in their appointment time. There was also a lack of a virtual waiting room kind of experience for the patient. So some of the barriers we encountered when trying to move this to a more integrated solution is, of course, we were working with multiple systems that didn't talk to each other at the time. So we were working with Meditech, which is our EMR, like I mentioned. It's also our electronic legal record at Fraser Health. And so they were booking in the CWS module in Meditech, which is the community-wide scheduling module. And then they were also, we were also looking at how could we integrate that with a virtual visit solution. So at the time, we wouldn't be able to do that with Zoom, but we had already invested in Fraser Health in Microsoft Teams as our corporate communication solution. So could we integrate these two solutions and use our BizTalk, which is our integration engine at Fraser Health, and integrate those two systems? So that's what we did in this to kind of streamline this virtual visit experience is we used BizTalk to integrate Meditech with Microsoft Teams in an app called Corollary Virtual Care, which is provided to us by a vendor called Callian. So this app would reduce our duplicate admin work. It would also decrease our manual steps required to book virtual visits. And what we would do is deliver that integrated solution to improve remote workflows for scheduling of appointments, requesting and obtaining patient information, and clinic capacity. So on this next slide here, I'll go through the solution in kind of a stepwise fashion. You'll see that same workflow with the barriers we encountered at the various points there. So how this would start now is the clerk would select a virtual appointment in Meditech, and they would book that appointment in Meditech. The system would create a Teams meeting and display the appointment in the Fraser Health Virtual Care application and send an appointment notification to the patient. The patient would receive the new appointment notification in the Teams meeting link. So the clerk was now only having to work in Meditech, which was their original workflow, and they didn't now have to go book in another solution. The system would also configure electronic questionnaire or form for various appointment types. So if there's a form associated with the visit, the system would configure that form and send that to the patient along with their meeting link. The patient can submit the questionnaire electronically at any time before their appointment. And then 72 hours before an appointment, the system would also send an appointment reminder to the patient. So the patient, as you can see, would either receive an appointment reminder via email or SMS. At the time of the appointment, the patient clicks the meeting link to join the video call, and the provider conducts and completes the appointment. The system then also takes that questionnaire that the patient received and converts it into a PDF and sends it back via an integration back into Meditech. So as you can see, this solution has been, we piloted this about a year ago in Fraser Health and was quite successful in the evaluation. So since then, we've expanded the solution. We've rolled out to, I think 12 clinics now. There was the initial 2, and we've now rolled out to an additional clinics. We've rolled out to neurology, mental health and substance use, diabetes, and cardiac clinics in Fraser Health. We're also now progressing on rolling out to further clinics. We have over 3,600 appointments, visits completed, 4,100 appointments scheduled right now, and we have 54 active clinicians. We are actively rolling this out in Fraser Health because of the wide success. And some of the highlights we have is the reduction in the time consumed it takes to book the appointments, as well as improved patient experience. So some people hadn't even seen their patient's face in 2 years. So now they're able to do that using this video visit solution. Thank you. Here's my contact information if you need to get a hold of me.
Perfect. Thank you so much, Brianne, for your great presentation, and to each of you for all the interesting presentations today. Next up, I want to invite all of you of the attendees to join the exhibitors for some networking and discussions in the virtual trade show. You can access that at the top of your screen. Thank you again and have a great rest of your day.